Perfect. Yes, perfect.
Okay. So thank you very much for the organizers for inviting me to give this talk. My name is Daniel Masso, and I did my PhD in Dr. Laura Soucek's laboratory at the Vall Institute of Oncology, VHIO, in Barcelona. And then I moved to Peptomic, which is a spin-off company of VHIO, founded also by Dr. Soucek, together with Dr. Maria Polier. And today I want to talk to you about how MEK inhibition can be a novel anti-metastatic therapy in breast cancer. We work on MEK, which is a transcription factor that is a central node in cancer. MEK is deregulated in many tumor types, and it acts downstream of many oncogenic signaling pathways, such as Notch, Wnt, or different receptor tyrosine kinases. And it activates several of the hallmarks of cancer, such as proliferation, support of the tumor microenvironment, or blockage of the anti-tumor immune response. These features together lead to tumor growth and survival. So MEK could seem an ideal candidate for cancer therapy, but to date, there is no direct MEK inhibitor in the clinic yet. And this is because of several reasons. First, MEK was deemed undruggable for many years because it is needed for normal tissue maintenance, meaning that if we inhibit MEK, we could cause severe side effects. Also, MEK is a protein located in the nucleus because it is a transcription factor. So a therapeutic that targets MEK should be able to reach this elusive cell compartment. Also, MEK are actually three proteins, c-MEK, n-MEK, and l-MEK, that can have overlapping functions in some contexts. So one should be able to inhibit them all to achieve the maximum potential of MEK inhibition. MEK also does not have an active site, so we cannot target it with conventional small molecules. And finally, MEK has a controversial role in metastasis. There are publications that claim that MEK is pro-metastatic and others that claim that MEK is actually anti-metastatic. So one should be cautious when inhibiting MEK in a metastatic setting. How does MEK work? MEK actually belongs to a network of transcription factors that also includes MAX and the MAT proteins. And these members of the family can form homo or heterodimers that bind DNA through a region called the VHLA-zip domain. MAX can form homodimers, but MEK can only form heterodimers with MAX, and MAT can also form heterodimers with MAX. MEK and MAX can bind to sequences on the DNA called e-boxes, and together they activate the transcription of MEK targets that lead to proliferation, transformation, and apoptosis, which in a context in which MEK is deregulated causes cancer. MAX homodimers induce cell cycle arrest, and MAT and MAX heterodimers induce differentiation. More than 20 years ago, Dr. Soucek designed HomoMEK, which is a MEK dominant negative. HomoMEK is actually the VHLA domain of MEK, but it harbors 4 amino acidic mutations that alter its dimerization specificity. As I mentioned before, MEK needs to bind its natural partner MAX to be able to bind the DNA, and they together sit on these sequences called e-boxes to activate transcription of MEK targets. What happens though when we have HomoMEK in the cell? HomoMEK can do 3 things. HomoMEK can form heterodimers with MEK, sequestering it away from the DNA. It can also form homodimers, and it can form heterodimers with MAX. HomoMEK homodimers and heterodimers with MAX can also bind DNA, but they don't have the capacity to activate MEK targets. So in this context, what we have is HomoMEK acting as a dominant negative of MEK and blocking MEK signaling, leading to decreased proliferation, cell cycle arrest, and death of tumor cells. Throughout the years, we have demonstrated that expression of an HomoMEK transgene is very effective on the treatment of cancer, on primary tumors, independently of what's the type of tissue and the driver oncogene distributions. We have done that by genetically modifying cell lines or mouse models with an HomoMEK-inducible, doxycycline-inducible HomoMEK cassette that can be expressed at will, and we have observed a very strong therapeutic impact in models of papilloma, pancreatic cancer, glioblastoma, lung cancer, and more recently, melanoma. Here on the right, you can see a model of non-small cell lung cancer that expresses transgenic HomoMEK. And we see that on top, we have a lung section that shows many tumors, while at the bottom we have the same mouse model treated with omomic in which tumors have disappeared. So treatment with omomic, we demonstrate that not only that there is a therapeutic window for MYC inhibition in vivo, but also that,
Eres un petardo.
that there was no appearance of side effects in these animals. As I have mentioned, MYC has a controversial role in the metastatic process because there are several papers describing that MYC has a pro-metastatic role, but others that claim that MYC is actually anti-metastatic. We wanted to shed light into this controversy, and we decided to test the effect of omomic in metastatic disease. For that, we chose breast cancer, and in particular, triple-negative breast cancer as our model disease, because it is a metastatic disease and because MYC has been found amplified in 50% of triple-negative tumors. We hypothesized that inhibition of MYC by omomic in this tumor type will be effective in both preventing and treating metastasis because MYC is involved on several of the hallmarks of metastasis, such as EMT and invasion. The first thing we did was infect a panel of breast cancer cell lines representative of all the molecular subtypes of the disease with a doxycycline-inducible omomic cassette. And when we activated omomic, we observed that it very significantly decreased proliferation in all the cells, and it did so by levels of expression. There was a positive correlation between the amount of omomic the cells were expressing and the effect, and there was no correlation with the mutational landscape, indicating that all cells are equally sensitive to omomic. As expected, because MYC is implicated in several of the checkpoints of the cell cycle, we saw that this decreased proliferation was caused by a decrease in DNA synthesis during the S phase of the cell cycle, and also by an arrest in the G0, G1 phase. For all in vitro experiments, we used our omomic cassette, and we also used a GFP control. Then we wanted to focus on the metastatic features of omomic in breast cancer cells in vitro. So what we did is use MDAMB231 cells, which, as you know, are a benchmark for metastatic triple-negative breast cancer, and we performed 3 different experiments. The first one was a wound healing assay, in which we saw that omomic was able to decrease the time of closure of this wound, indicating that cells migrate less in the presence of omomic. We also performed the classical void-in-chamber migration assay, in which the cells have to migrate through a porous membrane through a gradient of FPS. And we also observed that omomic was decreasing by half the migratory capacity of these cells. And more importantly, we performed an invasion assay in which we coated these tranches with a matrigel layer that mimics the extracellular matrix. That means that the cells, to be able to cross this barrier, need to secrete the proteolytic enzymes that they will need to secrete in vivo to reach the bloodstream. And by this experiment, we saw a very significant decrease of the invasion capacity of the cells. Since MYC is also implicated in angiogenesis, we wanted to check whether conditioned media of cells expressing omomic was less capable of inducing tube formation in endothelial cells. And for that, we used this assay in which we treated cells with omomic and then used the media to induce tube formation in cubic cells, and saw that omomic was able to decrease by 50% the number of tubes that were formed in these cells, confirming that omomic is also an anti-angiogenic therapy. Very encouraged by these results, we decided to move into an in vivo setting. We used the same MDAMB231 cells with inducible expression of omomic and inoculated them orthotopically into the mammary fat pad of mice. And when tumors were established, we treated them with doxycycline to induce omomic expression or with sucrose as a control. What we saw is that omomic was able to significantly reduce the growth of these tumors, as seen by the image here at treatment endpoint. This was 4 weeks of treatment, and also by tumor volume and tumor weight at experimental endpoint. And as expected, we saw that this reduction in tumor size was caused by decreased proliferation and increased apoptosis, seen by immunofluorescence of Ki67 and cliff caspase-3, respectively. We also stained for omomic to confirm that these tumors were expressing the omomic transgene. We are interested mainly in the metastatic setting, so we performed 2 in vivo experiments to assess the effect of omomic on metastasis. The first one was a lung colonization experiment in which we inoculate MDA-MB231 cells through the tail vein of the animals, and we follow the colonization of the lung. We treated these mice for 5 weeks with sucrose or doxycycline, and we looked at metastatic spread by 3 different techniques. The cells express luciferase, so we were able to follow them by iris imaging, and we observed that tumor burden was reduced in the lung of these mice by treatment with omomic. However, this allows us to follow only the total tumor burden, but we cannot follow individual lesions. So we performed also CT scans, and we observed that this reduction in metastatic burden was caused by both reduction of the number and also the size of these tumors. Finally, since the resolution of CT scan is not enough to look at micrometastases, we performed classical hematoxylin and eosin staining of tumor sections, of lung sections, and we observed that omomic again was able to reduce the number and the size of these micrometastases. To then test a more clinically relevant model, we inoculated the cells orthotopically and removed the primary tumor, and then treated metastases that had established through the natural mechanism, so coming from the primary tumor. What we observed is that mice that were not treated with omomic showed metastatic progression and actually had to be euthanized due to excessive metastatic burden, while mice treated with omomic not only showed decreased growth of the lesions, but in some cases we even saw eradication of metastasis. This can be seen by quantification of bioluminescence intensity at experimental endpoint, and also by counting the number of organs with metastasis at this experimental endpoint. We were extremely encouraged by these results, but at the time it was thought that omomic was a very good proof of principle for MYC inhibition, but it could never become a drug because the omomic protein was too big and bulky to be directly delivered into drugs. We decided to challenge this, and we recombinantly produced omomic in the lab in E. coli, and then we labeled it with a fluorescent dye and added it to the culture media of cancer cells. In this case, these are non-small lung cancer cells, and we saw an unexpected property of omomic, and it was that it had cell-penetrating capacity and it could also reach the nucleus. This unexpected property allowed us to patent its use for the treatment of cancer, and that's when we started Peptomic to be able to develop MYC inhibitors based on omomic. We wondered whether this omomic mini-protein synthesized in the lab could be used as a drug, and if it had cell-penetrating capacities also in breast cancer cells. We saw that it did. It entered breast cancer cells dose-dependently, and very importantly, it did its job. With this proximity ligation assay, we saw that omomic, once inside the cells, was able to heterodimerize with MYC, heterodimerize with MAX, and more importantly, reduce the number of MYC-MAX interaction in the cells. When treating cells with increasing concentrations of omomic, we saw a therapeutic impact, recapitulating what we had seen with transgenic expression, and we also saw the same alteration in the cell cycle profile, with a reduction in BRDU-positive cells and an arrest in G021. We also observed that omomic was able to cause cell death by increasing the number of subG1 cells. We then wanted to go a little further into the mechanism of omomic, and for that we performed a microarray analysis of MDA-MB231 cells treated either with the omomic transgene, so lentiviral expression of our omomic construct, or by treatment with the omomic mini-protein, exogenous addition of the mini-protein to the cultural medium. We observed that both treatments were able to shut down the MYC fingerprint by downregulating gene sets related to MYC targets, also to cell cycle progression, epithelial to mesenchymal transition, and breast cancer grade, while upregulating gene sets related to tumor rejection. At the individual gene level, we also looked at a panel of genes that were described as being MYC targets and being implicated in migration, metastasis, or survival of breast cancer patients in general. And we saw that omomic, both type of omomic treatment, were able to up or down regulate them in the expected direction. We validated the regulation of this panel of gene sets by RT-qPCR. And more importantly, we looked at patient databases, and we saw that within the downregulated genes, which are 7, patients that harbor alterations in at least one of these 7 downregulated genes by omomic have actually shorter overall survival, very significantly shorter overall survival, meaning that with omomic, we could potentially revert this. Additionally, we observed that among patients with alterations in one of these, at least one of these genes, there was the top altered gene was actually MYC itself. Very encouraged by this, we decided to test if the omomic mini protein could be a therapeutic tool against metastatic breast cancer. So here we use the mini protein to pre-treat breast cancer cells and inoculate them in our lung colonization experiment. We assessed lung colonization after 3.5 weeks, and it's very important to say that these mice were never treated with omomic. We only pre-treated the cells almost 1 month before inoculation, and that was the only treatment. What happened in this experiment? We observed that very significantly, cells pre-treated with omomic had less number of lung tumors, while the mean tumor area did not change. This is expected since these mice never received omomic, but this diminution in seeding was enough to reduce the total tumor area in these animals. This indicated us that omomic can actually decrease the seeding of the cells into the lung. Then we wanted to check whether omomic was able to be used as a systemically administered drug. So for that, we treated mice with intravenous injections of omomic twice a week, and we performed 2 experiments. In one, we used fluorescently labeled omomic to check whether omomic reached the target organs, and in the second one, we performed a 4-week treatment to assess the efficacy of omomic. In the biodistribution experiment, we saw that we were significantly reaching mammary tumors and also tumor-bearing lungs. So we were reaching our target organs. And in the efficacy experiment, we saw that intravenous treatment of the omomic mini protein was able to reduce tumor growth seen by both caliper measurements over time and also by CT scan at the experimental endpoint. To finish, we decided to perform a longer-term experiment in a more clinically relevant model, which is a triple-negative breast cancer patient-derived xenograft. We used a biopsy from a patient of the Vall Hospital and inoculated it subcutaneously into NMRI-naive mice. And when tumors were established, we treated those mice with biweekly injections of 50 mg per kilo omomic intravenously. We observed that, again, we were significantly reducing the growth of these tumors. And more importantly, we were able to extend the survival of these mice, and we were able to see no significant side effects in terms of weight change for long-time treatments for up to 70 days. This data and many other results were the basis to start a clinical trial to assess the safety and efficacy of omomic. And we are currently at this stage, so we are very encouraged with this clinical trial. We are actually in the phase 1 assessing safety, and we hope that in early or mid 2022, we will be able to start our phase 2 trial to assess its efficacy. I just want to finish by thanking everyone that contributed to this study, mainly the Socheck Lab, present and past members, also Peptomic, and other groups at Vall d'Hebron, so the Arribas Lab, Serra Lab, also CIEMAT in Madrid, and the Larson Lab at the Karolinska Institute, who is assisted with the proximity ligation assays, and finally, the funding agencies, because without them, this work would not be possible. Thank you very much for your attention, and I will be happy to take questions.
Thanks a lot for this talk. So this is really great, targeting MYC. I think since I remember everybody wants to do that in Burkitt lymphoma and all other kinds of diseases. So you go now for breast cancer in this context. So there's a question in the chat. Does omomic targets a specific MYC type?
So we have seen that omomic is able to bind the 3 members of the MYC family. So by co-IP, we have seen that omomic can bind CMYC, LMYC, and NMYC. So it targets them all. Also, we have to take into account that all forms of MYC bind to the boxes on the DNA. So one of the mechanisms of action of omomic is actually binding to the DNA itself and occupying it. So the MYC members cannot bind the DNA. So that would be effective against them all.
So the next question, there are a lot of questions now. So excellent talk. To my knowledge, there are no currently specific drugs to target MYC. Is it true that MYC is regarded as undruggable? So you demonstrate. Yeah. So yeah. How can you drug it? So this would be the question from Even Gout.
So in the clinic, there are some indirect MYC inhibitory strategies. So that PET bromodomain inhibitors, they have been shown to deregulate MYC and downregulate MYC actually in some contexts, but they are not direct. They target other pathways that end up deregulating MYC. In our case, yes, this is a direct MYC inhibitor. To our knowledge, it's the first one to reach the clinic. And it does so by the mechanism I explained at the beginning. So it is a dominant negative approach. So what it does is bind MYC and also bind to itself and occupy the boxes on the DNA. It's not a classical inhibitor.
So the next question comes from Gunhild Sommer. Very interesting talk. Many thanks. Does OMO-MYC work also with MYC-N, or I think there's a spelling error. Gunhild, what do you mean?
Yes, sorry for that wrong keyboard I'm working with. Yes, exactly. MYC-N is the question. Does it also interact with MYC-N? Did you do any studies showing that MYC-N amplified cell lines also react on your nice new drug?
Yes, so we did not do these studies ourselves, but we have collaborators that have tried OMO-MYC on MYC-N amplified tumors. And yes, we have also a therapeutic impact. And also, as I mentioned before, we have seen this interaction between OMO-MYC and MYC-N by co-IP experiments.
Very nice. One more question. Did you do any more studies about side effects? As you mentioned in the beginning, it's a very central protein. So I would worry about that. Do you have any data about it?
Yes, we're also very worried about that. So that's why I think it's one of the reasons why no MYC inhibitors have been developed for a long time. We have two ways of looking at this. The first one was by using this transgenic expression of OMO-MYC. These were mice that had expression of OMO-MYC in virtually all cells of their body. So this is a good way to look at side effects. We saw that we had decreased proliferation in the proliferative tissues. So we saw shortening of the villi in the intestine. We saw decreased spermatogenesis in the testicles, and we also saw in the skin, we saw thinner skin because of the cells proliferating there. However, these side effects were not severe, so absorption of nutrients in the intestine was preserved, and there were no weight loss, no severe conditions in these mice. And what is very important is that when we stop the treatment, when we stop giving doxycycline to the animals, these tissues would regenerate and go back to their original state. So we could be doing metronomic treatments for week on, for week off, and maintain the mice alive and healthy for a long period of time.
This would be exactly my question. How is the phase 1 trial planned? So how do you give the drug, as a metronomic treatment or a pulse treatment? So
it's a weekly treatment. So it's once a week intravenous treatment.
Intravenous treatment. Okay.
Yes.
And did you check also, because I missed that, the hematopoiesis? So did you have changes in the hematopoiesis of the mice? Because MYC is very, very important for the hematopoiesis.
Yes. So for that, we had to use another model because the first one we were using did not show expression in the hematopoietic tissues. But with another model, we saw it. And there was, again, decreased proliferation in some of the hematopoiesis, but it was, again, compatible with life. Mice were still healthy, and it was also reversed by withdrawal of the treatment.
Okay. Okay. So this is a very important trial. So if you really got the magic bullet against MYC, this would be, I think, for you a very, very good drug, and for us also, because I would also use it in many.
Too.
So there's a final question. This is for the metastasis field. So you did, when I'm getting right, you did in the treatment where you investigated the metastasis, you treated the cells before you inoculated them, correctly? So, but did you also did the trial where you did first the tail vein injection and then did the treatment? without the untreated cells. Did you also check this, that you block metastasis by this kind of approach?
So we did the experiment by pre-treating the cells because we always get the question that since Omomic is so effective in reducing proliferation and inducing death, we always have the question that if we treated metastases that are already there, are we affecting them because we are basically reducing proliferation, or are we really impacting on the metastatic phenotype? So the invasion, the seeding, and all these metastatic concepts. That's why we did the pre-treatment, because we wanted to check if the cells had the capacity to colonize the lung without any further treatment. But that's why we did it this way. With the Omomic transgene, yes, we performed the experiment you mentioned. We treated with doxycycline the mice, and we saw a reduction in metastasis. We have not done it with the mini protein. So this is something that we are very interested in doing now, inoculating the cells and then treating with Omomic.
Because this would be very important. As a clinician, we think that the seeding has already happened when we diagnose the patient. So we cannot stop the seeding. What we can stop is the colonization. So you should check if it's also possible to block the colonization. I think this would be very great if we can demonstrate this. So we are 2 minutes far, or too late. So really, thanks a lot for this very great talk. And please send me the results of your phase 1 trial. I would really looking forward for these results. And then we are coming to the next speaker.